Thank you very much, and a very good morning to everybody. I will be providing this talk on behalf of my colleagues. Where we are now and consideration for the next generation of postnatal prophylaxis, and I'll be focusing on program reviews that we have conducted at WHO. So just as an overview, I'll just go over very quickly what the current WHO recommendations for infant ARV prophylaxis are. These recommendations were provided in the 2016 guidelines and carried forward in the 2021 guidelines. And I would just like to focus mostly on the enhanced postnatal prophylaxis. We all know that the recommendation is to give a dual ARV prophylaxis for infants who are at high risk of vertical transmission, and in children who are breastfed and remain at high risk of acquiring HIV, the recommendation is to give an additional 6 weeks of either AZT and nevirapine or nevirapine alone for a total of 12 weeks. That is just a reminder of the data that supported the development of these guidelines and the references in the guidelines. So enhanced postnatal prophylaxis includes once and twice daily ARVs. We are familiar with the table over here on dosing and the dosing changes. And the alternatives. However, the alternatives are either not readily available in resource-limited settings, and or they may have challenges with administration. And we'll come back to this a little bit later. Just a reminder of what we have as ARV formulations for neonates and infant dosing. And if you look on the lower bottom part of the slide, we'll notice that it shrinks for neonates, the ARVs that are available. We are quite limited with the formulations that we can give to neonates for postnatal prophylaxis. But postnatal prophylaxis is just one component of a package of care for pregnant and breastfeeding women and exposed infants. There are several components with different time points and decision points, making implementation sometimes complex for frontline health workers. So we need to put postnatal prophylaxis in context of the bigger picture of what the frontline health worker has to do. So on the top half of this timeline, we have what the services are for the negative mothers, and remember what services need to be provided for the positive mothers on ART with viral load tests. And then we have all this package that is meant for the exposed infant that the frontline health workers need to remember, including decision points on whether the infant is low risk or high risk for postnatal prophylaxis, and then make decisions on which package of ARVs they receive for prevention. So in 2021, many of you may have seen this policy review that we conducted in 18 countries of the 21 priority, which are the high prevalence countries in the Afro region. And it revealed 9 distinct postnatal, enhanced postnatal prophylaxis regimens. However, I'll be presenting the update of this review. We carried out another policy uptake review in the Afro region. 31 countries participated. A questionnaire was circulated through the WHO offices in the Afro region, and the program officers were responded to the questionnaire with the updates of their policies and their recommendations in their national guidelines. So 16 countries were low prevalence countries and 15 countries were high prevalence countries. And we found that 32% of the country guidelines include retesting in the postpartum period per the recommended time points. Viral load testing, about 60 or 58% of the countries included viral load monitoring per WHO algorithm time points in their guidelines. And enhanced postnatal prophylaxis. We'll note here that the majority, 58% of the country guidelines, include enhanced postnatal prophylaxis for all infants who are exposed to HIV, as opposed to what the guidelines recommend for providing enhanced postnatal prophylaxis for those at high risk. So only 42% of the country guidelines include enhanced postnatal prophylaxis for high risk infants. Toxicity monitoring is only conducted in 58% of the, is included in the guidelines for 58% of the countries. And when we go to the regimens, what we found is this complex set of regimens in the different countries in their policies. The responses showed that there were at least 17 different enhanced postnatal prophylaxis approaches. Some countries did not specify the duration of their regimens for enhanced postnatal prophylaxis, so those are not included in the different approaches. And only 3 countries adopted WHO recommendations on target population, regimen, and duration. So you'll find that a number of countries are giving enhanced postnatal prophylaxis to all the infants. There are different regimens ranging from mono enhanced postnatal prophylaxis to triple regimens, ranging from 6 weeks to the end of breastfeeding, and their different time points here. So we'll find that Nigeria, Rwanda, and Madagascar adopted enhanced postnatal prophylaxis for high-risk infants per the WHO guidelines. There was also variability in the postnatal prophylaxis provided to infants who are identified as exposed during the postpartum period. And we find 22% provide presumptive treatment, 35% provide dual, 29% provide single ARV postnatal prophylaxis, and 12.9% do not give any prophylaxis if the infant is identified as exposed during breastfeeding. Sorry, how do I go back? There is extensive variation, as we have seen, in the adoption of the policy, and key lessons from uptake and implementation in different contexts should be taken into consideration when shaping the development of future approaches. We need to ask ourselves, why are the approaches so varied? Look at the complexity. There are several time points. Look at the implementation challenges. Poor ART coverage, maternal ART coverage, viral load coverage, maternal viral suppression rates, stockouts of ARVs, loss to follow-up, lack of toxicity monitoring. And when we look at these wide approaches for prophylaxis, it is particularly evident that there is a fragmented and complicated procurement process when the countries are not aligned. I will not go into this because of time, but the priorities for the antiretroviral drug optimization, the PADO meeting that was held in 2021, highlighted, concluded with these 2 lists of prospective ARVs for in the one a priority list in the midterm, and a long-term list which included options for postnatal, what is believed would be an option for postnatal prophylaxis. But I believe this will be discussed by somebody else. And this is just a schematic of what the potential for the strategy for elimination of vertical transmission in the pipeline, the products, and we see we have something in the long term planned for postnatal prophylaxis. However, just to highlight what, and I'm concluding, just to keep at the back of our minds, what are we looking for in the ideal postnatal prophylaxis approach? It needs to be simplified. As we've seen, countries are struggling to implement this particular recommendation. It needs to be simplified. It needs to be accessible. There needs to be preterm and neonatal dosing for this approach. It needs to be effective. Then it needs to be short and long-term safety, a friendly formulation and easy to administer, and it needs to be harmonized. So in conclusion, my call to you, we need to also address this is the short term. What do we do right now? We need to support countries to adopt the current guidelines or streamline the postnatal prophylaxis approaches, because when it is this fragmented, the availability of the formulations to provide the different approaches is quite weak. So we need to also secure supplies of AZT and nevirapine in appropriate formulations in the short term, and finally review the viability of alternative postnatal prophylaxis approaches. I acknowledge my colleagues and I thank you very much for listening.